Hello everyone, how are you all? So thank you so much for joining today's session. So you know that we have been doing our free 2 week session so far. Now today's session is our last session for the free sessions. And within these 2 weeks, we have finished a couple of clusters which are very important for your exam. One of them was cardio cluster. We finished 3 cluster from the cardiac. Like one is syncope cluster, another is palpitation cluster, and another is chest pain cluster. And we also finished the vomiting cluster from pediatrics. So these are the clusters. Tonight we are going to do some role play on those clusters and questions so that we can find out that doing those theories was helpful or not. Okay, now sometimes we may miss some of the cages from our theory sessions. And in that case, what we do that when we do the role play sessions, we try to cover those as well so that nothing goes missed up. Clear? So tonight's session will be all role play. I would advise you, like, please try to participate in the role play. Whatever your preparation is, try to come forward and do some role play. Once you will start doing role play in front of lots of people, your confidence level will be very high. And then you will understand the difference between you and others. All right. So always try to do role play, and it's really, really important for your exam. So, who is going to do the first role play? And those who are in the Facebook, you guys will not be able to do role play. So, if any of you who are in the Facebook wants to do role play with me, obviously, please join the Zoom. It's very easy. You can easily join the Zoom with the Zoom ID provided in the group. What's your name? Who has written I can try? Yeah, Dr. Mukta. Yep, please come on in. I will unmute you. So it's become easier if you write your names. Otherwise, there are lots of galaxy. So your name is showing as a galaxy A something. Let me see and find you. Yeah, I think. Can you hear
Hello.
me, doctor?
Yeah, sure.
Okay, good. All right. So give me 1 minute. I will give you your question.
Okay. এই শুনতেছো? আমি রোল প্লে করতে।
All right. So so you'll get 7 minutes for your inside station time and 1 minute in outside. Okay, so one
Okay.
minute outside and 7 minutes inside.
Have you shared the case?
Not yet.
Okay. I thought that
Okay,
I won't see.
so let's start. So this is your case.
Okay.
All right. Hi, doctor. Can I check your ID?
Yes, this is my ID.
Okay, so this is your patient. Your patient name is Mary. You can start. Hello? Hello, doctor. I can't hear you. Dr. Mukta, your voice is not coming up. Hello?
Hello.
Yeah, your voice was not coming up, doctor. Okay, so start
N-
again, please.
now can you hear me?
Yes, I can hear you.
Okay.
All right. So again,
Okay.
so hi, doctor. This is your
Uh,
patient. Your patient name is Mary. You can start.
okay. Hello, Mary. I'm Dr. Mukta, one of the doctors here. Today I'll be taking care of you. So, Mary, how can I help you today?
Doctor, I've been having this chest pain for the last 4 hours, and it's really
Okay.
severe. I can't even take a long deep breath because of this pain.
Okay, I see. Can you score it for me? How severe it is?
It's 7, I would say.
I'm so sorry to hear about that, Mary. Uh, so, do you want me to arrange painkiller for you?
Yes, please.
Okay. I will arrange painkiller for you. Just wait for a while. You will feel better within a short period of time. Is that okay,
Okay.
Mary?
Yes, doctor. Thank you.
Okay. And Mary, just wait for a while. I talk to examiner about your health. Then I come back. Okay.
Okay.
So, hello, examiner. May I know whether my patient is vitally stable? That can
Yes,
I
your
can
patient is
proceed
vitally
further.
stable.
Hello.
Your patient is vitally stable.
Okay. Now, examiner. Uh, okay, I want to proceed with go to my patient. So,
Okay.
Mary, can you tell me a little bit more about your pain? Like is it whether going anywhere else?
No,
Okay. Is it associated with any nausea, vomiting, or sweating?
no.
Okay. And can you describe your pain?
It's a kind of sharp stabbing pain, doctor.
Okay. And do you think that your pain is getting worse with the change of posture or relieved by the change of posture?
Um, I think it gets better when I sit.
Okay. And is it worse by lying flat?
Yeah, I think so.
Okay. And may I know whether you have any flu-like symptoms before your this chest pain?
Yeah, I had some flu about 1 week ago.
And now, how is your condition? Is it well controlled with medication?
Yeah, I'm fine now. I don't have any flu now.
Okay. Um, and by any chance, do you hit yourself in the chest?
No,
Okay. Otherwise, do you have any associated tummy pain,
no,
or is it related to any food?
no,
And this chest pain, related to any exertion, like it's getting worse with exertion and relieved by rest.
no,
You have any cough, any short of breath associated with that?
no,
Okay. Otherwise, do you notice any weight loss, loss of appetite?
no, doctor.
Okay. Or any lump and bump, any part of the body?
No,
Do you think that your chest is short to touch?
no,
Okay. And okay. And do you smoke, drink alcohol, or ever try any recreational drug?
no, doctor.
Okay. Are you in any kind of medication?
No.
Okay. Now, I want to talk to the examiner about your condition. Then I will come back. Okay, just wait for a while. Thank you for sharing your all information with me.
Sure.
So, hello, examiner. I want to know the general appearance of my patient.
Patient is as it is, you can see.
Okay, any pallor, dehydration,
Nope.
any rash, lymphadenopathy.
No.
Vital sign is as stable as before.
Yes.
May I know the BMI of my patient?
BMI is 26.
Okay. Then I want to check the, first of all, in the neck, I want to check any raised JBP or any carotid bruit.
No raised GBP or carotid bruit.
Okay. Then I want to check the chest, like, first of all,
Normal.
okay. Like, cardiovascular is normal.
Yes.
Okay. Then also I want to check the chest, like bilateral and equal, any other
Normal.
sound. Okay. Then abdomen, uh, any distension, mass, or organomegaly.
All the physical examination normal.
Thank you, examiner. Any urine devistic blood sugar level available?
No.
And any chest X-ray, ECG available?
This is the ECG.
Okay. So I have to describe the ECG. Sorry, I didn't.
Yeah.
Okay. So examiner, sorry, is I have to describe with the examiner or
Yeah.
patient?
Yep. Examiner always.
Examiner. Okay. So examiner, first of all, I want to confirm the whether this ECG of my patient, Mary.
Yes. Yours.
Okay. So in this ECG, now I'm going to present 12 lead ECG of my patient Mary, and here heart rate is 75 beat per minute, and rhythm is regular, and here POF is followed by QRS complex, and there is I'm seeing some ST depression in lead 1, lead 2, uh, then then in the V1, V2, V3, V4, V5, and V6. So and um, so my interpretation is pericarditis.
Thank you. Your time is up.
Okay.
All right. Thank you, Dr. Mokta. Now, see that you have done really good. Thank you so much. Now, a couple of things we can add here, or now this case, most of the time PEFE will not be there, or if even if PEFE is there, they will help you. They will just say like how I give said you that everything is normal, like in that way. So it should not give you any trouble with the PEFE. Don't, because chest pain PEFE usually you will not find anything if it's a cardiac.
Mhm.
Now, investigation from examiner, if it is written and if you get a ECG from examiner, it's a good idea to always explain the ECG to the examiner, even if it is not given as a task.
Okay.
Sometimes if the examiner doesn't want to hear, then they can say you don't need to explain it to me, you can explain to the patient.
Okay.
Okay. Now the thing is, like, if there is no time, like if you
Mhm.
understand that you are running out of time, then
Mhm.
don't bother with the explanation to the examiner, don't ask it
Okay.
to the examiner.
Okay.
Okay,
Okay.
so if you ask it to the examiner will say, yeah, do it, like
Okay.
I did. So
Mhm.
in here, like if you think that your time is going really fast and you don't have enough time
Mhm.
to discuss diagnosis and DD, go to the diagnosis DD, finish that, and then if you get
Mhm.
some time, then explain ECG.
Okay.
Okay. But if in the task it is written that ask investigation from examiner and explain it to the examiner, then obviously you have to do that.
Okay.
Now, starting from the first, your
Mhm,
starting was good, so you asked for the painkiller, hemodynamic stability, but always remember, like, don't in chest pain case when you have to explain ECG most of the time, try
mhm.
not to lose a lot of time, because
Okay.
just in a very swift way finish
Okay.
your main things, like give the painkiller in a very fast way, and
Mhm,
also do some of the important thing for any chest pain clusters. Like,
mhm,
remember this patient, 58-year-old, so she's a high risk patient having a chest
mhm,
pain. So obviously,
mhm,
if it is a, like, for the last 4 hours if she is having pain, and it's a
mhm,
58-year-old patient, so we would follow all the cardiac protocol. At least, even if you don't want to give medications like aspirin or those sort of things, at
mhm,
least you have to hook this patient or attach this patient with the ECG monitor, and you have to at least send the blood as soon as possible for cardiac enzymes. So those are
mhm,
vital things, you have to do it obviously. Like,
mhm,
any chest pain in a middle-aged or elderly patient, your job is to give painkiller, ask the
mhm,
hemodynamic stability, and once
mhm,
you, most of the time their hemodynamic stability will be good, but still you
mhm,
have to do some of the things, like you have to send this patient to the resuscitation cubicle, attach the
mhm,
patient with ECG monitor, and ask
mhm,
the nurse to take a ECG, take the,
mhm,
so insert a IV cannula, and then take
mhm,
the blood for cardiac enzymes.
mhm.
Okay. And sometimes you need to give aspirin if you want, or even if you don't want, you want to do it later on, that's fine. But it's a good idea to start the patient with aspirin at least, to make sure
Okay.
like you don't miss these patients.
So I have to attach to the monitor, and I need to start the aspirin. What like it might be pericarditis or MI, whatever it is.
Yeah, like if you,
Mhm,
even if it's a
mhm,
pericarditis management is also aspirin and NSAID. So you're not
mhm,
doing
mhm.
any worse of these sort of things.
Okay.
You are,
Okay.
it just, if it is not a case of peptic ulcer disease causing chest
Mhm,
pain, then in
mhm,
every other cases aspirin will be a
mhm,
good choice. But
mhm,
we need to take that risk, because
mhm.
why, any chest pain in middle aged or elderly, we don't think that it's a peptic ulcer disease at first. We always think it as a AMI unless proven otherwise. So we'll try to prove that it's not AMI, but as long
Mhm.
as we cannot prove that, we will treat it as a AMI.
Okay.
Okay, so the main thing is, first of all, when you give the painkiller, you have to say that if you have any allergy to the painkiller, that's one of the thing
Mhm,
you missed. And
mhm,
also, those important thing, take the blood for cardiac enzymes, attach the ECG
mhm,
monitor, send the
mhm,
patient to the
mhm,
research cubicle. So these are very
mhm.
important for any chest pain patient.
Okay.
Okay, then after that, very
Mhm,
quickly, you have asked all the pain questions. Then you ruled out
mhm,
many differentials, like you ruled out cardiac differential, GIT. Then you ruled out musculoskeletal system, respiratory system, and then also you could rule out any rash in your chest, which will rule
yeah,
out your
herpes. Mhm,
herpes zoster. Yeah.
mhm,
And other than this, you did everything that's needed. You ask about smoking, alcohol, family history was important, like any family history of heart condition.
mhm,
If we have
mhm,
time, we can ask. If you
mhm.
don't ask it, it will not cause you any trouble. And any
Okay.
previous history of heart attack, angina, or ischemic heart
Mhm,
disease is very
mhm,
important. That means
mhm,
specifically diabetes, high
mhm,
blood pressure, and past history of angina is important to ask.
mhm.
Okay,
Okay.
so that's your history. And after
Mhm,
that, PFE, as you asked, is totally fine. In here, there is nothing to add. And
mhm,
investigation from examiner. So when you ask or when you discuss the ECG, you see that
mhm,
you told it's a ST depression. I understand
mhm,
that it was due to pressure, maybe,
mhm.
because you can see these are all ST elevation, not depression. Now,
Yeah, yeah,
you
I
know that.
that mistakenly told.
Yeah, I understand that. Now,
Mhm,
remember one thing, like, you have to play smartly in exam. Now, you know this
mhm,
case is pericarditis, just even
mhm,
asking the question. then you just
Mhm.
need to confirm it with the ECG. So you don't need
Mhm.
to say where, like in which leads you are seeing the ST elevation. How you can say
Mhm.
this ECG, that you can see that, well, this is the 12 lead ECG of my patient Mary, who
Mhm.
presented to me for
Mhm.
chest pain, left-sided chest pain for the last 4 hours. And I can see that heart rate 75 beat per minute, rhythm regular, then the P wave is normal,
Mhm.
QRS complex is normal, then there is ST elevation with concavity upward in most of the leads.
Mhm. Mhm.
Okay, if you say most of the leads, that will cover everything. You don't need to
Okay.
specifically say that lead one, lead two, and then
Okay.
that will kill a lot of time. So
Mhm.
obviously in here you can see most of the leads having ST elevation. So you
Yes.
can just say that.
Mhm.
And then you can say that it's a pericarditis.
Mhm.
Okay, in that way, it will just, you will have like 15 seconds you will lose for this whole explanation.
Yeah, yeah. Mhm.
And after that, diagnosis DD, you know how to do that. So you have to
Mhm.
give pericarditis and all other differentials.
Mhm.
Okay. And I think you
Mhm.
missed also where exactly is the chest pain. That's one of the important question.
Yes.
So
Yes.
patient
I
can
miss.
have chest pain in the right
Mhm.
side, or
Mhm.
so the whole thing will change if the pain in the right
Mhm.
side. Okay.
Okay. Mhm. I understand.
All right. No worries. Thank you. It was good. All right.
Thank you very much for your nice explanation. Thank you.
So, Dr. Samson Nahar, if I can't finish the task, but I was consistent or did right until my time was up, will it count as fail still? Yes, it will. Unfortunately, you have to finish the task. So in the exam, it's not even not likely that you have to understand that in all the tasks, your goal is to get at least four. So if you want to get six in history, obviously what will happen that in the DX and DDX, you will not get enough time and you will get zero. And eventually global score will come as zero. So the main thing is to, in the mind, the goal is to get four in every task. Okay, so that globally I can get a four in and pass the station. That's the goal. Never ever think that I will get 7 by 7 or 6 by 7. It's not needed. You just need to pass this station. That's your main goal. So in a way you will do, you have to divide it always. If there is four tasks in the exam, you don't have enough time. So you have to run and you have to be very fast. If there is two tasks, then you can be relaxed. You can ask every question what you have memorized. Okay, but if it's four tasks like this case, you have to be very very fast. And if you miss something is the hint in the history, that will not fail you because you have asked most of the important questions. That's all they want. Okay, so in that case you have to be very careful and try to finish the case first. If you want to add something, then you can add it after you finished your task. Okay, so who is going to do the next role play? uh, who asked that question? So doctor, like if the chest pain is on the right side, the case can be different because you don't have or you didn't get heart related pain in the right side. So most likely if you get right sided chest pain, then most likely it's a something related to your lungs. Could be pneumothorax, could be pulmonary embolism, could be also it could be your pneumonia. Okay, so these are the most likely causes because heart related causes doesn't come with right sided chest pain. But still you will follow the same thing. You will try to rule out everything like a chest pain cluster, but you have to be careful when you make your diagnosis. So I think Dr. Cookie Doe, she asked for the next case. You want to do next? And then Dr. Wafi Talukdar can also do. Dr. Cookie, you want to do it now? Yes. Okay, let me unmute you. I'm unmuting you. You have, I think you have to accept it in your, yeah. So can you
Yeah,
hear me, doctor?
yeah, I can hear you. Thank you.
Good. All right. Just give me a second. I'll give you your
Sure.
case. Okay. All right. Are you ready? Hello, doctor. Doctor, can you hear me?
Yes, I can hear you. Is it my case? You have a
Yes,
God
this is your
on your ship.
case.
Okay. You have a God on your ship, and the nurse report the problem of the neonatal. My doctor has seen that the patient and order investigation. You will be taken to the nurse in charge of the baby, take history and ask the physical examination, interpret investigation, and give the diagnosis and differential diagnosis. So you give me 2 minutes thinking, or I do right now?
Your time is 1 minute to think, and then we'll start with a 7 minute time inside.
Okay. So thank you. So let me know when my 1 minute I will finish. Thank you, doctor.
Yep.
So I got the ship and the nurse report a problem neonatal that occur overnight. So what is the problem? And the night doctor has seen the doctor and ordered some investigation. You we're talking with the nurse in charge of the baby, so I need to talk with the nurse and talk with the nurse and ask take history and physical finding from the nurse and interpret the investigation and give the diagnosis and differentials.
Hello, doctor. Can I check your ID, please?
Thank you, doctor. Here's my ID.
So this is your patient. This is the nurse who wants to talk to you. The nurse name is Sarah. You can start.
Thank you, doctor. So, hello, Sarah. Hello, Sarah. My name is Cook, one of the doctor today. So I'm
Hi,
the
doctor.
doctor to take care. Yeah, hi, Sarah. So from the north, I know that you are in charge a baby, and the baby have problem overnight. So may I ask you some questions and
Yes, doctor.
ask.
I was with the baby last night, and he's been having like frequent vomiting since last night, and he was delivered uh, just less than 24 hours ago. The night doctor also knew about this patient, and the night doctor did some investigation, including a chest X-ray, and he also tried to insert a NG tube, which was not successful. Now that's why I wanted to make sure that everything is all right, and if you want to do anything else.
Okay, thank you for your information. So, may I ask you some more questions? So, you said that the baby just 24-hour delivery, and may
Yes,
I know that the mother is fine at this moment? Any
yes,
complication?
mother is fine, no
Is it
complications.
vaginal delivery or is it the C-sections?
It's vaginal.
Sorry, I cannot hear.
It's vaginal.
Yeah, thank you. And apart from that, may I know that the baby when was born, is it eventful or any problem? The baby cry after deliver or anything happen?
It was uneventful, doctor.
Yeah, thank you so much. And another thing, may I know that during the pregnancy and on are there any infection, any medication or any complication with the mother, with mom?
No, there is no complication. It was all good.
Thank you so much. And apart from that, may I know that the baby about the vomiting? You said that the baby vomiting overnight. How many times the
Yes,
baby already vomiting? Vomit.
it's ongoing for the last 24 hours. I can't even count it because as soon as mother wants to breastfeed, he vomits everything out.
Okay. And may I know what is the color of the vomit?
It's just the breast milk is coming out.
Are there any green color?
No,
Okay. And any foul smell?
no.
Thank you. And is it related to the fitting or not?
Yeah, doctor, as soon as mother feeds, he vomits.
Yeah, and you said the doctor already put the nasal gastric tube in, and it's not successful. That's what you said.
Yes,
So the vomit still come out.
yes.
Okay. May I know that the baby have any fever, any rash?
No fever or rash.
How about the pee? Any changing in number of nappy?
I haven't seen this patient, I've seen this child like having urine output that much, very little amount.
Yeah. Apart from that, any difficulty of breathing?
Yeah, he seems to be in having some breathing difficulty as well.
Okay. Any cough along with that?
No,
Okay. Uh, Thank you, Sarah. May I ask some about the physical finding? So about how about the general appearance of the baby? Uh,
baby seems to be lethargic and drowsy.
okay. Are there any pallor, any jaundice?
No,
Okay. Any dehydration sign?
there is moderate sign of dehydration.
Okay. And I would like to do the quick cardiovascular examination as one to her. Any murmur?
Cardiovascular normal, no murmur.
Respiratory examination and bilateral echo.
There is very minimal effort of breathing.
Okay. And any ethic sound?
No,
Okay. Any repeaters? Any runs?
sorry.
Any repeaters?
What do you mean by that? Sorry.
Um, so um, okay, just keep going. So I would like to focus on the abdomen examination. So on the inspection, any visible distension, any mass visible?
Abdomen is full and distended.
Okay. May I know that any palpable mass,
No
any
palpable
tender,
mass.
any tenderness?
You cannot elicit tenderness in neonate.
Okay. And are there the bowels are present?
Yep.
So I would like to check with the consent of mom. Can you check for me the genitalia examination, the genital examinations? So on the nappy, did you see any red stone, red curly stone?
Nope.
Okay. Any ambiguous the genitalia?
Nope.
Okay. Thank you, Sarah. And good like, could you check the horn? Are there any dysmorphic feature?
Nope.
Okay, thank you, Sarah. So I would like to check, order the investigation. I would like to do the basic blood, including
Okay.
electrolyte, creatinine electrolyte, and I would like to order the X-ray. So the chest X-ray and the abdominal X-ray.
So you can see this is the X-ray.
Okay, so my task is the interpret the investigation. So I explain to Sarah or to examiner. So in the X-ray, I can see that the nasogastric tube is not go through. Yeah, sorry, I ran out of time. Yeah.
Yeah, that's okay. No worries. You tried your best, and it's nice that you have been trying. I know that you have started your preparation as a beginner now. So, as a beginner, you have been doing really nice. All right. So, you'll be fine. Don't worry. Now, this case is very complicated case, and it's hard because we haven't discussed this case in our theory session also. So, apart from that, you have done really good.
Thank
Now,
you.
let me discuss this case so that we can understand how to present it when it comes in the exam. Now, this case is about a condition called esophageal atresia plus minus tracheoesophageal fistula. It could be any of these two. It can come as a esophageal atresia or tracheoesophageal fistula. Both of them sometimes are more or less interconnected with each other. The question is like this, like so a nurse will report a problem with a neonate that occurred overnight, and sometimes they will give you that a night doctor already seen the patient, ordered some investigations, and you need to follow up those investigations. That investigation is nothing but the chest X-ray after inserting the NG tube, and you will find out the coiling of the NG tube, and that will give you the idea that it's a case of esophageal atresia or tracheoesophageal fistula. So your history will comprise of our vomiting cluster. So all the vomiting question and differential diagnosis you have to ask here. Physical examination, similar like our vomiting cluster physical examination, the format you have to follow. Investigation, you have to explain the chest X-ray mainly to the nurse, not to the doctor, and give your diagnosis and differential. Okay, so let us discuss this one. So the what is the history in here that it's less than 24 hours ago, this child was born. Most likely it was a vaginal delivery. There was no complication. And patient or the child is vomiting after every feeding, unable to tolerate any feed, past meconium already, nothing significant on birth or antenatal history. Night doctor inserted a NG tube. Patient is not stable. Obviously, this sort of patient may not be stable because nothing is going into the gut. Okay, so after the birth, everything is just vomiting out. So they will be nutritionally deficient also, not in respiratory distress. Vitally stable in here, it says on investigations. Now, X-ray was given, which showed coiling of NG tube in the esophagus, and they ask for the differential diagnosis also. Some of the differential diagnoses could be esophageal atresia, tracheoesophageal fistula, wrong placement of the tube, duodenal atresia. These are the DD. Now, this was the X-ray. If you look at this is the NG tube. NG tube should not never ever coiled like that if there is a patent esophagus. Okay, whenever this sort of coiling is there, we should think about either atresia or tracheoesophageal fistula. Now, how to find those out? That's important. Remember, if you think it as a case of esophageal atresia with tracheoesophageal fistula, some of the important findings will be that child will have frothy white bubbles coming out of the mouth. Very important. So you have to ask it, have you seen any frothing or white bubble coming out of the mouth? They can also having some coughing and choking when feeding. Vomiting will be usually non-bilious vomiting, which means whitish color. That means the breast milk only coming out, not greenish color. Very important, if it's a tracheoesophageal fistula, cyanosis will be there. So this is a very important physical examination. You have to ask it obviously from the examiner, because if it's cyanosis, we have to think about tracheoesophageal fistula. Difficulty breathing can be there, and tummy will be full and rounded and distended. Okay, so these are the main symptoms of esophageal atresia plus tracheoesophageal fistula. Now, if you look at this condition, there are many subtype of this problem. One, it could be just a isolated esophageal atresia. Some of the time it could be isolated tracheoesophageal fistula, or sometimes both can be there, esophageal atresia with tracheoesophageal fistula. The most common anatomy is upper esophagus ends in blind pouch. Okay, so what happens? This is the esophagus, and upper esophagus ending in the blind pouch. Then there is lower esophagus, and this lower esophagus or distal esophagus will be connected to your trachea. So let's assume this is your this is the trachea. With trachea, there will be a fistula in the distal esophagus. So this is the most common form, which also called H type. Sometimes they call it H type for this lesion. Now, sometimes this sort of patient can have bacterial association. You don't need to discuss it during your questionnaires. Just only during general appearance, you can ask it to the examiner that is there any dysmorphic features or any association of bacterial. Okay, you can just ask it. Even if you don't ask it, examiner would not mind about that. Now, the clinical presentation is very important. As I said, this frothing, bubbling is very important. Coughing, cyanosis, respiratory distress are common. And immediately after the feeding, child will vomit and have some regurgitation. Diagnosis, first of all, you have to try passing the nasogastric or orogastric tube, and you will be unable to do that. Now, in the esophageal atresia, what will happen? X-ray shows coiled nasogastric tube in blind pouch with no distal gash. So if it is a gasless abdomen, then we have to think about only esophageal atresia. Okay, so if your X-ray, now in here you cannot see any gash in the abdomen. Okay, if there is no gash in the abdomen, then it's esophageal atresia. Why we are thinking about gas? Because from the trachea air should come, right? Now if there is a fistula between trachea and esophagus, some of the air from your trachea can enter through the esophagus into your stomach and abdomen, and then you can get some gas in the abdomen. Okay, now if there is no fistula, you should not get any gas in the abdomen. Cool. So esophageal, if it's isolated esophageal atresia, there will be no gash in the abdomen, only inability to pass the NG tube with a coiling of the NG tube like that. If it's an isolated tracheoesophageal fistula, usually this is not very common because most of the time esophageal fistula is having some connection with the esophageal atresia as well, most of the time. But if we want to diagnose this, we have to do a esophagogram with contrast media. So usually this is not the case most of the time. So don't think about this one. If there is a fistula, like there is esophageal atresia with distal tracheoesophageal fistula, then what will happen? Because the upper esophagus is ending in the blind pouch, you will be unable to pass the NG tube. So there will be coiling of the NG tube. That's one finding. Another is that you will found there is large amount of gas in the abdomen. Okay, because due to this fistula, air from the trachea going through the fistula into your esophagus and then into your tummy. So this is how you will be able to diagnose it in the exam. In the exam, they will give you a X-ray. In the X-ray, if there is no gas in the abdomen with a coiling of the NG tube, then you diagnose it as a case of esophageal atresia. If coiling of the NG tube with gas in the abdomen, lot of gas in the abdomen, then diagnosis will be esophageal atresia with a distal tracheoesophageal fistula. Clear? If there is tracheoesophageal fistula, then obviously there will be cyanosis, there will be breathing difficulty, there will be cough when you try to feed the baby. Okay, so this will be the feature of tracheoesophageal fistula. Now, if you want to discuss about it with the patient, you can use this one. It's a very good guideline, or at least you can use it as a non-medical jargon. So first of all, you will say that most likely this child is having a condition called esophageal atresia. Do you know what it is? Now, most of the time, nurse may be able to know it, but nurse can say, no, doctor, I don't understand. Can you discuss this with me? Then what you need to do, draw a picture like this. So then you can say, well, let me draw a picture for your better understanding. So you can see this is the food pipe or esophagus, and food from the esophagus should come down to the stomach and then to the whole gut. And in front of the esophagus there is the windpipe or trachea, which will carry the air. Now, most likely for this child there is underdevelopment or absence of the esophagus. Or you can say in this way, the esophagus is a tube that transports food, fluids, and saliva from your mouth to the stomach. Trachea or windpipe is a tube made of some cartilage that's connect. You don't need to say this much. You can just say the trachea or windpipe is a tube-like structure which carries or transport air in and out of your lungs when you breathe. Esophageal atresia is a condition when the upper end of the esophagus ends in a blind pouch, which means that the esophagus is not well developed and it's not able to transport the food from the esophagus into the stomach. Now, if the food cannot travel from the esophagus into the stomach, everything the child is getting out as a vomiting. That's the esophageal atresia. And tracheoesophageal fistula, it's a abnormal connection between the windpipe and the food pipe, which means that anything you swallow can travel from your food pipe into your windpipe and can end up in the lungs. And it can cause serious infection in the lungs. And sometimes the air that you are breathing that can go from the windpipe into the stomach, and that's the reason you can see a lot of gas shadows in the abdomen. So this is when you are explaining the tracheoesophageal fistula. But most of the time, if it's a esophageal atresia, you will just need to draw a picture and say that most likely the esophagus that should carry the food from the mouth into the stomach, it is underdeveloped and ending in a blind pouch, so that whatever the child is getting, it's unable to get into the stomach, so it's coming out as a vomiting. Okay, so that's your esophageal atresia. So you can see that these are the most common types of esophageal atresia. So as I said, that esophageal atresia with a distal tracheoesophageal fistula is like that. Okay, so this is also common. When you will say about this, if you see gash in the abdomen with a coiled NG tube in the chest X-ray. And obviously this sort of patient needs a surgery for correction. Okay. Usually management doesn't come. Usually you have to give a lot of differential diagnosis. Clear? Any question from this one?
No, thank
In
you.
online, okay, doctor, thank you. So in online platform, how we can use draw and paper? So this is a good question. You can like, it is still, we don't know how they are going to do that. What can happen is that they will ask you to take a paper in front of you and a pen in front of you, and then you can draw it and you can show it to the patient. It's easier to show it if you are in a video setting. So your video will be open, and at that time you can just draw it in the paper and you can show it. It's always a little harder than the face to face, but still you have to do it. Clear? So this case is important because it's the recent question cases. So in this case, you have to be prepared for this case. Okay. So obviously you have to ask all the vomiting question. Remember our vomiting cluster question. So ask the hemodynamic stability in here, which is very important. Ask the sign of dehydration, and then start with the vomiting questionnaires. Ask all the vomiting question, then rule out DDs. What are the DDs of vomiting? So some GIT causes, non-GIT causes. What are the GIT causes? Intestinal obstruction, gastroenteritis, then you have got intussusception, incarcerated hernia, okay? So, and then non-GIT causes. So all those infectious causes you have to ask. Ask the well baby, binds, and then finish the history. So history will be a lot of important question to ask. Clear? And interpret investigations. So when you discuss this to the patient or to the nurse, you have to say in this way. So this is the x-ray of your, this is the x-ray chest and the upper part of the tummy of your baby. If it's not nurse, then you will say of the patient or of the child. Now in the x-rays, some of the shadows are black and some are white. Whitish are mainly which contains the fluid and blood and the bony structures. And the blackish are which are the structures which contain air. Now if you look at this x-ray, you can see on the both side, these long tubular shadows are are the child's lungs. That's because it's contain air, it's blackish. In the middle, you can see this is the heart, and this is the upper part of the tummy. Now, at the top, you can see there is a coiled structure. This is the NG tube, which the other night doctor has tried to pass. Normally, in a normal baby or patient, the NG tube should not be coiled. It should go into the stomach without any problem. In this child, you can see the NG tube is coiled and you cannot see any gash in the abdomen. So most likely I'm suspecting it could be a case of esophageal atresia. Or sometimes it could be a case of wrong placement of the tube. It could be duodenal atresia. It could be esophageal atresia with tracheoesophageal fistula. Then give other differentials of vomiting. Okay, clear guys? Any question? Who wants to do the role play next? Dr. Wafi, I think. Sepsis as a differential diagnosis is unlikely unless the child is having fever or child is having rash. Okay, sepsis, like vomiting can be a presentation of sepsis. You can say it, it will not harm, but it's not a most likely thing because children having sepsis usually have fever. All right, let me unmute you, Dr. Wafi.
Thank you.
All right. I'll just give me 1 minute. I'll give you a case. All right. So you're ready?
Yes.
Okay. So this is the case. Oh, crap. Just a second. Yep, this one.
Okay. Just,
Hello, doctor. Can I check your ID?
all right. Yes. Here's my ID.
Okay. So this is your patient. Your patient name is Jenny. You can start.
Hi, Jenny. I'm Dr. Wafi, one of the doctors here today. So, from the notes, I've come to know that you've been having a bit of palpitation or irregular heartbeat for the last 2 hours. Would you like to tell me more about it?
Yes, doctor. It just started when I was just exercising, and suddenly I'm feeling like my heart is racing, and I can feel it like some butterfly is running or racing in my chest. It was really uncomfortable.
So, was it constant for the whole 2 hours, or did the irregular beat last like 15 minutes normal, and then like at specific intervals? Was it throughout the whole 2 hours?
No, doctor. It was just for, I would say, half an hour, and then it went
Okay.
out
So,
by its
four
own.
episodes every half an hour, was it?
Yeah.
Okay. All right. And is this the first time that this has happened?
No, this is not the first time. Just about a month ago, also I had this similar one, but it was very short in duration, so I did not
Mhm.
get in contact with any doctor at that time.
Okay. And sorry, with this irregular heartbeat, have you noticed any fever, headache, dizziness, nausea, vomiting?
Mm, no,
Okay. And just to double check, any chest pain?
no chest pain.
Okay. And recently, in the past few days, have you noticed any change in weather preference, loss of weight, loss of appetite, any diarrhea or constipation?
Doctor, can you ask me one or two questions at a time?
Oh,
I
okay.
can't actually
Sorry.
remember what you were
Okay.
asking.
Sorry. Recently, have you noticed any change in weather preference or diarrhea?
No,
Okay. Any loss of appetite or constipation?
no,
Okay. All right.
no,
And sorry, any are you on any regular medication?
no.
Okay. All right. And do you drink alcohol?
Sometimes,
Okay. And is it within normal limits, like two standard drinks?
yeah, very occasionally, doctor.
Okay. All right. And any chance that you've used any illicit drugs?
No,
Okay. All right. And any family history or any personal history of any heart disease that I should be aware of?
no,
Okay. Any chronic medical illness like high blood pressure, diabetes?
no,
Okay. Any sudden death in the family recently?
no.
Okay. All right. And do you normally consider yourself to be an anxious person or worry about trivial things?
Doctor.
Okay. No. Okay. All right. And any allergies?
No allergies.
Okay. And just to confirm again, last question, that did you notice any tremors when you had the irregular heartbeat? Okay, all right.
No.
Thank you for confirming that. So if that's okay, I would like to go to my examiner to get some physical examination findings. Is that okay?
Yes.
Okay. So examiner, I'd like to know the general appearance of the patient. Do I see any pallor, jaundice, lymphadenopathy, or rash?
No.
Okay. Um, okay, as the complaint is palpitation, I'd like to do cardiovascular examination first and then examine other systems. So on cardiovascular examination, oh, sorry, just one thing, vital signs first. Sorry, examiner, can I know the pulse, temperature, blood pressure?
Pulse is 150 and blood pressure is 110 by 60, temperature 37.
All right. Examiner, on cardiovascular examination, do I see any visible apex beat, visible beats?
No.
Okay. On auscultation, apart from S1, S2, any added sound or murmur?
No.
Okay. Any raised JVP?
No. So all
Okay.
other physical
Okay.
examination is normal.
Okay. All right. Thank you, examiner. I'd like to ask the patient one more question before I comment on the ECG. All right, John, are you someone that normally drinks a lot of tea or coffee?
I used to, doctor. I used to like drink a lot of coffee. Yes,
Yeah.
5 or 6 a day.
Oh, okay. All right. That's a little bit too much, but anyway. So if that's okay, I'd like to go back to my examiner. Examiner, may I have the ECG, please?
Yes, this is the ECG.
Okay. Examiner, this is the 12-lead ECG of the patient, Mary, oh, sorry, Jenny. So on the ECG, I can see that the heart rate is about 150 and it looks like it's irregular. Okay. There is no ST elevation, no ST depression. And aside from that, all other findings, there is no abnormality that I can notice. So examiner, from the uh, ECG, I'm suspecting most likely the cause is atrial fibrillation, but other causes could be myocardial infarction, atrial flutter, heart block,
Explain the
MI.
DD to the patient, doctor.
Okay. All right, Mary, from the ECG, I can most likely what you're having is an atrial fibrillation. So just basically a medical term meaning you have irregular heartbeats. Okay. So now there are the things that I still want to rule out because it's very important. If we don't, as they can be life-threatening. So first, I'd like to rule out a myocardial infarction, which is basically a heart attack, and an atrial flutter, which means there's an irregular rhythm in the heart, so the heart can't pump blood. Sorry, am I over time?
Not yet.
Okay, yeah, and then the other thing I'm suspecting that just could be simple anxiety. Okay, um, then any excess tea or coffee, which is also a contributing factor to atrial fibrillation. Okay, but for now, it's very important that first I'd like to send some bloods just to rule out the differential diagnosis that I've mentioned, and just so that we can treat it. But with atrial fibrillation, since you are having it and you've had more than one episode, I'd like to maybe send you to the hospital, okay, for a review by the cardiologist, because obviously we need to know
Time up.
how long this has been happening, because if the heart doesn't pump blood properly, there's a risk of clots developing and you developing a stroke, which
Time up,
can be
doctor.
life-threatening. Okay, okay,
Thank
I'm
you.
done. Yeah, I'm done.
All right. Hi. Thank you so much, Dr. Wafi. It
Thank
was
you.
nice. And you have tried to finish it in time. That's the most important thing that you have done. I'm really happy. And it's good that you have been very fast. Now, some of the things that also need to be addressed is like try not to miss the important stuffs, or try not, like, it's really important to uh, follow the format. Now, I understand that getting 4 or 5 tasks, it's really tough. Now this one in here, whenever you will first see that PFE from examiner or PFE card from examiner, it remember that it will not take a lot of time. So don't get stressed, because
Okay.
card means that you just have, they will give you a card or in online exam, they will show you the findings, and cardiac examination findings are always usually normal, unless it's a syncope and they can give you some murmur. Otherwise, in two other cluster, PFE will be normal most of the time. So it will not take a lot of time. So try to take a little bit more history and ruling out other DD.
So
Investigation
sorry
from
for this. If
examiner.
I would have asked you for the PEFE card, you would have given it, right?
Yeah.
Oh, okay.
So
Yeah.
normally, or even like if you don't ask me, I
Yeah.
would supposed to give it to you. But see that whenever you started to ask me, I say that please proceed or everything is
Oh,
normal. Sometimes the examiner can give it to you, give the card to you, or if they like you, they will say that examination is normal, proceed to the next task. So they are actually helping you to finish the task. Most of the examiner do that if they like your approach. Okay. Now let's start with the history first. First of all, in this case, you can see that it is a case of palpitation. We haven't said that this patient is having irregular heartbeat. You have been saying about that, like you are totally sure that this patient is having irregular heartbeat. Maybe patient is having SVT. At that time, there will be regular heartbeat, still having palpitation. Maybe patient having atrial flutter. Also, there will be regular heartbeat, but having palpitation. Only atrial fibrillation will have irregular heartbeat, which will present as a palpitation. So don't think just atrial fibrillation will be the exam case. Anything can come as a palpitation. Even it may be not a case of heart, maybe it's a menopausal case. Middle-aged women can be a menopause, and ECG can be totally normal. Can be. You have to be like totally clear in your mind that this case can be anything. I don't know what is this case is all about. Okay, in the exam, that's the main thing, that you are open to every findings. Now, first of all, don't say irregular heartbeat, always address it as a palpitation. So you as you started, so first of all, give her
sorry,
some
just to
reassurance,
cut you
say
off. So, how do we say palpitation in lay terms? Because a lay person may or
racing of
may
the
not.
heart.
Oh, okay, racing of the heart. Okay.
Yeah. So we say racing of the heart. Sometimes some of the patient understand palpitations also.
Okay.
So anything like if they, you can try with the palpitation. If they don't understand, then you can go with the racing of heart that they understand very well. Okay. Now history. So in the history, first of all, when the patient comes to you, give some reassurance that everything is fine. You don't need to worry. I'm here with you. And then you haven't asked the vitals because it's already given. That's a good thing. If it's not given, you have to ask it. And when you ask vitals, obviously, as in the examination, in the PF, you ask vitals, but I said pulse is 150. You did not ask me the rhythm. Always try to ask the rhythm, because at that time you will get a very good clue to the diagnosis. Because I will give you the thing like, is it rhythm is regular or irregular? If it is irregular, most likely AF, atrial fibrillation. If I say rhythm is regular and pulse rate is high, so it could be either SVT or atrial flutter, because these are the important cases. Or I haven't seen WPW syndrome. Also keep it in mind that it can come in the exam. All these are related. Okay. And after that, when you start asking history, ask about palpitation. Now you have to ask all the details about the palpitation. So can you tell me more about what exactly have you been doing at that time? As you asked, like, when did it started? Is it the first time? If it is not a first time, then how many times have you had it? And then what exactly were you doing? How long each episode last? How did it stop? Did it stop suddenly, or did you do anything to stop it? So some of the question. Now you ask most of the question, that's all right. And then associated with the palpitation, usually you will ask the CVS related question, which means any chest pain, any shortness of breath, any dizziness. You ask, now very important not to ask 4 or 5 symptoms at one go. Because I am a good role player. That means I'm saying as per the exam, if I am a good role player, I will give you the hint, or I will stop you, say that, doctor, if you continue like that, I will not answer your question. Some of the role player are like that. They will be very rude to you if you ask 4 or 5 symptoms. Or some of the role player, they want to fail you, so they will just answer a couple of the symptoms that you have been asked, because it is very hard to go with the flow. That if you ask 5 symptoms at one go, I will just remember the last 2 symptoms and I will say no if I don't have that, and I will miss the first 3 symptoms. Okay, so always highest 2 symptoms in one go, like any chest pain, shortness of breath, no doctor. Any dizziness or lightheadedness, no doctor. So in this way, we have to proceed. Okay, even though I understand it's very much hard to go with the time, but it's important not to ask more than 2 symptoms. Okay, because we can miss the important symptoms. Then you ask about those questions. After that, some of the DD are related to CNS, not very important. You can ask in one go, like any headache, weakness, any head injury, but not important. If you miss it, that's fine. But important is endocrine. You ask about thyrotoxicosis, very good, and pheochromocytoma, hypoglycemia. These two are very important DD. So for hypoglycemia, you have to ask question like, did you miss your meal today, or do you have diabetes? Then for pheochromocytoma, any episodic headache, sweating, or flushing of the face, these two important DD. Then you have electrolyte abnormality. You can ask about any nausea, vomiting, any excessive sweating. Okay. Then infection, you ask about fever, so that's important. Infection can lead to palpitation. Then what you else have it? You have menopause, middle-aged women. You have to ask when is your last menstrual period, and any hot flashes. So you have to ask it obviously. Then some of the important will be to rule out psychiatric causes, as you ask, anxiety disorder. Very good. It's very important to rule that out in a middle-aged women. Then panic attack, any how is the mood also you can ask. Very important question you ask is the SADMA, that means alcohol, recreational drugs, tea, coffee. Those are important. Family history of cardiac death, sudden cardiac death, you ask, important. So some of the important question you ask, some of them you missed. That's totally fine. As long as you ask most of the important questions, they are happy with you. But the endocrine causes is very important. Pheochromocytoma and hypoglycemia should be asked. And infection, electrolyte abnormalities, those are important. Then after that, you ask the ECG. Now ECG, PFE is okay. You don't need to bother with PFE. Investigation for a case of palpitation, ECG is important, as you asked ECG. Now explanation of the ECG was not good enough. You have to be a little bit more detailed in here. So what you have to say, that as we used to do, everything you have to comment on. That means heart rate, rhythm, P wave, QRS complex, ST wave, QT interval. All these things you have to comment at least. Like, it will not take a lot of time, because this is a task. And if you want to pass this task, you have to explain in a way. So the important aspect is, maybe when I gave you the heart rate, it was 150, but in the ECG, it doesn't mean it has to be 150. Sometimes when the nurse did the ECG, maybe it was a little low. Okay, so you cannot rely on what I say. You have to rely on the ECG. Now in here, it's not 150, it's more likely 75. Okay, because 1, 2, 3, 4, even more than, so it's not 150. And then rhythm is regular. If you look at here, the rhythms are regular, it's not irregular. And what you can see here, this is not P wave, this is called flutter wave or sawtooth appearance, very typical sawtooth appearance. So this is a case of atrial flutter. Okay, so flutter also is important for the exam. I totally missed it. Where did it go? Okay, this one. So you can see in here how you have to explain. You have to say, this is the 12 lead ECG of my patient. I can see the rate is 75 beat per minute, rhythm regular. There is no P wave. P wave has been replaced by flutter wave. QRS complex is normal. No ST wave changes. Okay, and QT interval is normal. I'm suspecting from the sawtooth appearance and regular rhythm with a tachycardia that most likely it's a case of atrial flutter. Okay, so this is the atrial flutter, which is a 3:1 block. Most likely, you don't need to comment on 3:1 block. You just say atrial flutter. That's fine. After that, see the next one, your explanation. So explain the diagnosis. So explain diagnosis how we have shown you in the palpitation cluster. It's a very good explanation. Try to draw the heart and show that this is heart, this is the electrical impulse, and if the electrical impulse is generating abnormal impulse, then your heart is beating faster. So something, just draw something and explain it in a very, like in 2 or 3 line. Try to finish the explanation. Then your differential diagnosis, you will have to finish it. Most of the time you will not get this much task, so don't stress. This PFE most likely to not be there. So mainly history, ECG, explanation of the ECG, diagnosis, DD. Implication sometimes can be there, sometimes not. What is the implication of atrial flutter? Mainly a stroke or heart failure. Okay, so a stroke or heart failure is mainly, this is the most important to implication. That means complication. If management is not a task, don't talk about management. All right, because you have more important stuff to finish. Clear, Dr. Wafi? So these are the things that even if it's a very easy case, sometimes it can be hard in the exam. It's all about lots of practice, and with the practice you will be fine. I can see that because you have the confidence in your voice, and that's very important. Okay, keep it up, do some more role play, and always be open in the exam. Think that anything can come in the exam, because you know that there is, that this patient having atrial flutter, you will know if you are open to any diagnosis. Cool. Any question, guys? So ECG, we did the ECG class. So you have to say in this way that this is a 12 lead ECG of my patient John. I can see the pulse rate. Pulse rate is 7. It's not, it's more than, it's less than 75, but if you say 75, that's fine. So pulse rate is 75 beat per minute, rhythm regular, P wave is absent and replaced by flutter wave. QRS complex is normal. There is no STT wave changes. QT interval normal. And I'm suspecting most likely it's a case of atrial flutter. Okay,
Sorry, just
who
to
wants
double
to do
check.
the next role play?
Sorry, before
Yeah,
one last
okay.
question with this one. So from the history, there's no way to actually tell it was atrial flutter. Like, what are we looking for, or is it just we have to judge by ECG?
Yeah, right. Yeah, you cannot actually say. And that's why if every palpitation cages will have a ECG. Okay. Yeah, there is no way we can say atrial flutter just by the history.
Thank you.
No worries. Thank you. So let's take a 10-minute break, and then we will do more role play. And whoever wants to do role play, be ready for it. Can I know that who is going to do the next one so that we can start as soon as possible? Dr. Shirisha, you raised your hand. Do you want to do that? Yes, good. All right. So we'll just start in the next session, next after the break. Okay. So 10-minute break and we will start again. Thank you. Hello everyone, let's start again. So, Dr. Shirisha, are you online? Okay, so let me unmute you. Can't find you. Where are you? Okay, I've unmuted you.
Yes, sir.
All right, so this is your station. This interpretation is to the patient.
Okay.
Hi, doctor. Can I check your ID?
Yes, examiner, this is my ID.
So the nurse wants to talk with you. The nurse name is Jenny. You can start.
Okay. Hi, Jenny. I'm Dr. Sirisha, and how can I help you, Jenny?
Doctor, I've got a child here who's been just 24 hours ago he's delivered, and he's
Mm-hmm.
been having this continuous vomiting since birth. I'm just really worried about this child.
Okay. Okay, Jenny. And can you please excuse me for a while? I need to know some findings from the examiner. And
Sure.
examiner, can I know is the patient vitally stable to proceed further?
Yep.
Okay, thank you, examiner. Okay, Jenny, so okay, I have checked with my examiner and this baby is stable at the moment. So I would like to ask few questions. Can you please tell me about more about his vomitings?
Yes, doctor. As I say that he's been having continuous vomiting since the last 24 hours after the birth.
Mm-hmm. Okay, all right. And can I know the color and is there any blood in the vomiters?
No blood, but it's a kind of yellowish green, I would say.
Yellowish and green. Okay. And is it foul smelling?
No,
Okay. Is it a small volume or large volume?
it's sometimes small, sometimes very really large.
Mm-hmm. And is it associated with feeding?
No, doctor, it's happening like with or without feeding.
Mm-hmm. Okay. All right. And is it forcible?
No.
No, all right. And along with the vomiting, is she having any, did you observe any tummy distension?
Yeah, the tummy seems really distended.
Mm-hmm. And is there any lumps in the tummy or in the groin area?
No,
No, okay. And is she having any fever?
no.
No, okay. And so, can you tell me, um, is there any, how it says, water works and bowel habits?
The water works, I would say, doctor, like the number of wet nappies is really reduced. I haven't
Mm-hmm.
seen much,
Okay.
and he hasn't passed the first stool yet.
Okay, he has not passed. Okay, all right. And is there any red currant jelly stools? I mean,
I
okay, I'm
haven't
sorry,
seen.
you told. Yeah.
Okay. And all right. And can you tell me about the birth? How was, is it term or preterm baby?
It's a term baby.
Term baby. Okay. And did the mother has any complications during pregnancy or delivery?
No.
No. Okay. And is a heel prick test done?
Yeah, it was not, I think, normal.
It was normal. All right. And okay. And so how is the baby? Is the baby active?
Baby seems to be lethargic and drowsy
Mhm.
sometimes.
Okay. And any family history of cystic fibrosis?
No.
No. Okay. Okay, Jenny. Thank you for your history. And examiner, can I know the? Okay. And Jenny, I would like to advise you certain investigations to be done. Okay. And you
Mhm.
need to do the full blood. We will send the full blood examination and ESR CRP, and also we will send the blood culture and liver function test, and also the X-ray needs to be done.
Okay,
And
doctor. We have already done the X-ray of the abdomen.
mhm, okay. Okay. And okay. And can I speak to the mother? Can I know the mother's name, examiner?
It's Sarah. You can
Okay.
talk with the nurse and you can
Yes.
explain it to the nurse.
Okay, examiner. And so Jenny, this is the X-ray of the baby. So you can see that the white and there are white and black shadows. The white shadows indicates that there are air, and the black shadows indicate there are bones. And usually, what happens in intestines, there will be gray shadows. But can you make out that certain black shadows which are rounded in the right side of the upper tummy?
Yeah, I can see.
Okay, so this indicates that there is some kind of obstruction in the tummy. Okay, and um, most likely, as the baby has not passed the stool, I mean the meconium, within 24 hours after the delivery, and also it could be the distal intestinal obstruction, or it could be meconium ileus. Okay,
Hmm.
and it could be even the tracheoesophageal fistula, but there is no features of any cyanosis or any distress in the baby. And it could be duodenal atresia. Okay. But the X-ray features are not in favor of the duodenal atresia. It could be even Hirschsprung disease. Okay. And it could be even sepsis. And so, are you with me so far? Do you have anything for me to repeat?
Yeah, I'm fine, doctor.
Okay. Thank you, John.
All right. So you finished?
Yeah, yes, doctor.
Yeah. All right. That's good. Really great that you finished it in like you still have 1 minute 40 seconds in your hand. So that's really nice. Now, what you can do, you can ask a little bit more question in the history, but you asked most of the important questions. That's I think that's good. Now, in here, uh, give some reassurance to the nurse also. Like nurse is worried, you can say, "Well, Jenny, thank you so much for letting me know. Um, me and so I will be here with the child and
Mm,
we will work things together to find out what's going on. Don't worry." Now,
okay, doctor.
then you say that in the vitals, just try to add sign of dehydration. So say in the examiner, ask differently that doctor, is there any sign of dehydration? That sounds good actually in this case.
Okay.
After that, you started asking vomiting question. That was nice. So all the vomiting question you asked, and then you ask about associated question also. Then after that, you ask about bowel habit and waterworks. Now, do not ask bowel habit waterworks in one go. I think because waterworks and bowel habit has lot of DD for this case. So you
Okay,
can
doctor.
ask one by one. So how is the waterworks of the baby? And there are some other questions like any change in color or smell of the urine. Have you
Okay.
have you found out that there is reduced number of wet nappies? So you can ask this way. And also the stool, try to ask detail. So how is the bowel habit? Has he passed the meconium yet or not? Any tummy distension, as you asked. You also asked about any lump in the groin, so ruling out hernia. That was good. So you ruled out most of the important one. One of the important one, now intersusception is not very important for this case, so you didn't ask it, so it's all right. Now Then you ruled out in sorry, excuse me, just take some water. So you ruled out fever. Now I would say because you have some time and there is no PAF here. So what you can do, you can ask those infectious causes in detail, like pneumonia, otitis media, gastroenteritis, UTI. So try to ask it, because even if there is no fever, if you ask those questions, that sounds that you are trying to rule out infectious causes of vomiting.
Okay, doctor.
And then you ask, will baby binds, that's all right. So most of the important question you ask in the history. Then in the investigation, usually investigation, you can talk it with the examiner always, don't talk it with the nurse. And then investigation, so most important investigation in any vomiting in the children is your x-ray abdomen or x-ray chest. So, and after that, you can take some blood, as you said, full blood, urea, electrolyte, creatinine, full, then liver functions, blood culture, sorry, especially if there is features of sepsis. And also you can check urine. Urine MCS will be very good because some of the child with UTI will present with vomiting. Okay. So those are the important investigation. So once you see the here, so this is the X-ray. What you can see, this is most likely you can see that there is lots of loop of bowel and filled with gas shadows. So explain in a way. So this is the X-ray of the tummy and also the upper part of the hip and pelvis. So in the X-ray, some shadows are whitish, some are blackish. The blackish are which contains the air, and whitish are actually the bony structures. Now in the tummy, you can see lots of blackish shadows all over the tummy that's normally not present in a normal baby. These are the gas shadows, and this most likely represents some obstruction of the passage of bowel contents, which I'm thinking most likely is the intestinal obstruction. It can be a small bowel or large bowel obstruction, which I cannot appreciate at the moment. Now, the differential diagnosis of neonatal intestinal obstruction, these are the differentials. So you talked about most of it. So intestinal obstruction with bilious vomiting. So this child having bilious vomiting, like yellowish green, right? So it could be anything: meconium ileus, meconium plague, Hirschsprung disease, malrotation volvulus. So any of these can be the diagnosis. Then if there is intestinal obstruction with abdominal distension, then you can discuss about same thing like meconium ileus, meconium plague, Hirschsprung, ileal atresia, imperforate anus. So imperforate anus is one of the important DD also, because child did not pass meconium yet. So what if there is imperforate anus? Okay. And intestinal obstruction without bilious vomiting. If there is no bilious vomiting, then we would think about duodenal atresia or pyloric stenosis. Okay, so you can actually say all these differential diagnoses. In this case, your main diagnosis will be intestinal obstruction, and then you will say it could be any of it. Just explain this, because you cannot actually say which is the diagnosis just based on the history and based on the X-ray. It could be any of it. Now, if you look at here, so you can you can say in this way that this condition is known as intestinal obstruction. It could be due to any causes. It could be cystic fibrosis, which causing the thickening of secretion of the bowel content, and then resulting in blockage of the content, which actually gives the meconium plaque syndrome or meconium ileus. Could be due to abnormalities in the nerve supply of the lower part of the gut, called Hirschsprung disease. As your child hasn't passed the meconium yet, so it could be a possibility as well. Sometimes decreased blood supply to the gut during development of the baby can result in a condition called intestinal atresia. Sometimes there can be abnormal rotation of the gut during development called malrotation. So you can say any of these differential. These are the most important one, like cystic fibrosis causing thickening of the secretion resulting in meconium plaque or meconium ileus, could be ileal atresia, could be malrotation volvulus, could be Hirschsprung disease, could be imperforate anus. All right. So these are the most important DD. And then lastly, you can say duodenal pyloric stenosis, and sepsis. There's the last differential. Okay.
Thank you.
All right. You did good. So no worries. Thank you.
Thank you, doctor.
Who wants to do the next one? Dr. Alia? Yeah. Okay. Give me some time. I'll give you the question. Just hang on some time. Just give me a second. I'm finding out that if there is anything we have missed out so that we can do it now. All right, I got your case. Are you ready? I have unmuted you. Can you hear me? Dr. Alia?
Hello.
Yep. Can you hear me?
Yes.
Good. All right.
Can,
So this is your case. Your is 1 minute started. Hi, doctor. Can I check your ID, please?
hello, doctor. This is my ID.
So
Hello,
this is your patient. Your patient name is Ali. You can start.
hello, good morning, Ali. This is Dr. Ali, one of the medical doctor in this practice today. I'm going to take care of you. Very nice to meet you.
Nice to meet you, doctor.
I understand from the notes that you have got swelling, leg swelling, that I'm really sorry to hear, and I can see that also. That you are worried also. I am here to help you, and I will try my best to give you appropriate management as much as I can.
Thank you,
Okay,
doctor.
so okay, so that would you please excuse me for a moment? That just a quick check with my examiner that everything is okay with you to take further.
Yeah, sure.
Hello, examiner. Is my patient vitally stable to take further history?
Yes.
Okay. So, okay, would you please tell me a little bit more about your swelling, that exactly what happened?
Yeah, doctor. So initially it was just in my one foot, the right foot, which was swollen, and it was just up to my ankle. And since this last 1 week, it's just getting really worse. And I can see my both feet is swollen now, and it's up to the knee at the moment. I don't know like why it's getting worse.
Okay, I'm really sorry to hear it. And is it for the first time?
Yes, doctor.
Or did it happen? Okay. And the swelling, do you have any pain or with the swelling?
I had pain initially, and usually, like at that time, I came from a long flight from New Jersey, and then I had some pain in my leg at that time. But right now, I'm not having any pain. It's just the swelling which is bothering me.
Okay. And with that, do you have any clotting problem? Your family members or other clotting
No, doctor.
disease with it? Okay. And do you have any shortness of breath or chest pain with it?
I feel short of breath at the moment, yes, doctor, because it's been really hard to get sleep because of the shortness of breath at night.
Okay. And when you feel shortness of breath, during rest or during exercise or during activity?
Actually, when I lie down, doctor.
Oh, I understand. And how long have you been this shortness of breath?
This is also getting worse over the last 1 week.
Okay. Okay. And do you have any fever or cough with it?
No,
Okay. And that uh, uh, do you have any history of any uh, chest injury?
no,
Okay. And any nausea, vomiting, or excessive sweating with it?
no,
Okay. And that any okay. And by any chance, do you do smoke or drink alcohol?
no, doctor.
Are you in, are you on any medications right
No,
now? Okay. And that okay. And um, okay. Thank you for. And may I know that when is your last menstruation?
it's been not happening for the last 5 years, doctor.
Yes, okay. Do you have any hot flush or any like this?
No, doctor.
Okay.
I'm fine.
Okay. Thank you giving me all information. And I need to talk to my examiner. Uh, Examiner, I would like to know my patient's general appearance.
As you can see,
Okay. And the vitals is same as before. I would like to know the pulse and blood pressure.
the pulse is 90 beat per minute, blood pressure is 110 by 80.
Okay. Any, okay. And that I would like to know that any anemia or any jaundice present or not with it.
No anemia.
I would like to know the my patient's BMI.
BMI is 34.
Okay. And I would like to check if other system examination is normal. I would like to do the focus cardiovascular system examination. I'd like to check the neck. Is there any enlarged jugular venous pulse present or not?
There is raised JBP.
Okay. And I would like to check the by inspection any visible cardiac impulse present or not.
Nope.
And by palpation any change of position of apex beat.
No.
By auscultation any murmur present or not.
No murmur.
Okay, I would like to check the full upper limb and lower limb examination, including cranial nerves, and also any
Neurological
looking
examination
also.
normal.
Okay, I would like to know any office test available. I like to know the by blood sugar level and ECG.
ECG not available. Blood sugar is normal.
And okay, thank you, examiner, and thanks, Jenny, for waiting. That from the history, you have given very good history, and I examined that you have the condition. What I am suspecting, I am thinking so many reasons regarding this, but what I'm suspecting in you have the condition which we call the congestive heart failure. Have you heard it before?
Doctor, what it is? No.
Okay, and
All right.
don't worry.
Time up, doctor.
Hello.
Thank you. Hello, doctor. Can you hear me?
Yeah, yeah, yeah.
Yeah. All right. Dr. Alia, it was very good. Now, it's a little bit of more fast is important in here because this case, it's like I understand that we haven't done it in our theory. That's why I kept
Yeah,
it
yeah,
for
yeah,
today.
yeah.
Yeah, it's a little new case for most of you, and that's why I was actually taking some time because I know that this case was missing from our theory session, so that I can discuss it with you tonight. So this is a case is most likely it's a heart failure, but the case is not about getting the diagnosis. Case is about how you find out your diagnosis and how you rule out the differentials of bilateral leg swelling. That's the case is all about. Now, whenever you find a patient with bilateral leg swelling, you always think about any failure. It could be heart failure, it could be liver failure, it could be renal failure. That is the most likely cause. Sometimes, most of the time, unilateral leg swelling comes with cancer, especially for reproductive age group patient, or any female patient can have any, like sometimes it could be cervical cancer, ovarian cancer, any cancer of the reproductive organs can cause unilateral leg edema. That's also important to rule out. Even if it's a bilateral, we'll try to rule that out. Then sometimes deep vein thrombosis can come with unilateral leg swelling. Now, that was a trap for you when I said that I came recently from New Jersey. It was a long flight. It's just making you confused. And sometimes the role player will try to do that. Obviously, you should understand that unilateral leg swelling is more common in case of DVT, but in this patient, we are having bilateral leg swelling, all other features of heart failure. So we will not think about DVT here, but it will be one of our differential, obviously. Okay, so start with the history. In the history, first of all, reassurance was very good as you did. Then second one, hemodynamic stability was good. You said that. Now we start with the leg swelling. So ask, can you please tell me more about it? And since when it started, how did it started, suddenly or gradually? Then I have given you all the things that how it started and everything. Then you can say that, can you tell me what's the extent of the swelling? Is it painful? Is there uh, any skin break in it or any skin tear in it? That's one of the important thing, because sometimes it could be just an insect bite, or sometimes it could be some allergic reaction causing leg swelling. We don't know that, but we have to rule that out. Those are unlikely causes, but it's still, because this is all about DD. If we ask it, that doesn't make us bad. It makes us a safe doctor. So ask about those questions, and then you will say, along with the swelling of the leg, first of all, rule out local causes. So any pain, any redness, any break or tear in the skin, okay, any itchiness, have you noticed any rash in the leg along with the swelling? So these are all local causes. So do you have any history of allergy, any history of insect bite? Okay, it's just local causes you are ruling out. Very unlikely to be allergy causing leg swelling, but it's still we are just trying to rule that out. After that, move upwards. So any, then you'll start with the failure question. Any chest pain, shortness of breath, racing of your heart? Now, this patient will give you shortness of breath. So shortness of breath, you have to ask in detail. So can you tell me more, since when? When do you get short of breath? Okay, like, is there anything makes it better, anything makes it worse? Then I will say that, well, I feel more short of breath when I lie down. Okay, that's one of the important finding, orthopnea, right? So do you need to use more than one pillow? Yes. Do you need to, do you wake up in the middle of the night catching up for breath? That's paroxysmal nocturnal dyspnea. Very important finding. After that, so you ask about chest pain, shortness of breath, palpitation, then ask about some lung causes, even it's unlikely. So any cough, because heart failure patients sometimes have pink frothy sputum with some cough. So patient can have cough. So you ask about any cough with sputum production, any fever. All right. Then any yellowish discoloration of the skin, any history of liver disease. How about your urine? How about your water works? Any reduced amount of urine output? Any history of kidney disease? So you're ruling out liver failure, kidney failure. Any loss of weight, loss of appetite, any lump or bump anywhere in your body. That's how you're ruling out cancer. Cool. So if you just ask these DDs, then you are fine. These are the most important DD of bilateral leg swelling. And then you will just ask about past medical history, especially for heart failure. We need to make sure patient doesn't have any previous history of angina, ischemic heart disease, or any history of um, hypertension. These are important, or any valvular disease. Just ask it directly. Then medication history, SADMA, and family history of any heart condition. Okay. So this is how you are going to finish. Also during the swelling question, ask that is there any other swelling anywhere in the body, especially in the tummy or in the face. Then PFE, you have missed some of the important things. So it started with the general appearance, then pallor. One of the DD, as you asked, anemia is a good DD to ask. So you, in the differential, you can ask like, do you feel tired and fatigued these days? Any loss of blood from anywhere? So anemia can cause heart failure that you can rule out. Then in the general appearance, then pickled, you will ask, mainly in the pickled, important is pallor and edema because it's a heart failure. So edema is very important to ask. Then start with the neck. So JVP, carotid bruit, JVP will be raised here. After that, start with the cardiovascular as you did. But heart failure patient will have bibasilar capitation. So important to ask about respiratory system. So respiratory system is more important than asking a CNS in this case. After, and also when you do the cardiac examination, ask about S3, S4 rhythm. S3 is for heart sound because you can get S3 gallop rhythm in heart failure. Then bibasilar capitation. Go to the abdomen, ask specifically for any tender hepatomegaly. Very important to ask it. Then after that, go to the leg, ask for any leg. So ask for the swelling. So doctor, can I know that is there any leg edema? Yes. Is it pitting or non-pitting edema? And what is the extent of the edema? Is there any tenderness in the leg or cough? So a lot of things to ask in the leg. Cool. And then lastly, office test, urine dipstick, BSL, ECG. Then diagnosis will be congestive cardiac failure, draw the heart and say what is heart failure, that it means that heart is unable to pump blood to your body. So there is excessive accumulation of fluid in everywhere in the body causing swelling of your leg. So, then also shortness of breath because of accumulation of fluid in your lungs. Okay. Then there could be underlying cause why you are having heart failure. Then it could be hypertension, ischemic heart disease, valvular disease, anemia. Any of this can cause heart failure. We will do more investigation to find that out. Other than this, it could be other DD. So what are the DD you will give? So liver failure, renal failure, any cancer, allergy, insect bite. Okay, so just give all these differential diagnosis. So that is your case about bilateral leg swelling. And yes, very good that you can give hypothyroidism also. Hypothyroidism can present with swelling in the leg. Cool. Any question?
No, thank you.
All right. So those who are in the yeah. So if they ask about investigation in heart failure case, your investigation will be full blood examination to rule out anemia, ESR, CRP, and then liver function, kidney function, BSL, lipid profile, ECG, then echocardiogram, okay, and also thyroid function test. You don't need to specifically find out the underlying cause of heart failure in history, but obviously the previous medical history is important. Yeah, we rule out malignancy by asking about the loss of weight, loss of appetite, lump or bump. We should rule this out. Okay, so this was about our today's session. So as you guys understand that normally we'll take another session on role play of this two cluster, because still there are some of the other important questions that we are left with. But this is how usually we take our session. This 2 week session is for your understanding that how our course will be in the next 5 months. From the next week, we will start our ongoing course. If still there is someone who wants to join the course but haven't been contacted with us, or is still due for the payment or something else, make sure you finish it as soon as possible so that you can get all the benefits of our software, of our course and classes and everything. Okay, it was really nice to get many of you during the sessions. I hope that when the exam opens, you guys will get more benefit from me. We'll take lots of more free sessions so that you guys can get idea about the exam. All right. And yeah, keep updated always and try to do hard work. It's really important. And try to prepare yourself. Don't wait for the exam to start. Okay, prepare yourself in a way so that when exam starts, you can at least register for the exam. That sort of preparation you should have. So normally we take role play after every cluster. Like we finish cardio cluster, then we do the role play of that cluster. Like this, we do the role play. So that, see that today I have made sure like if anything missed in our theory session, that should be finished first. So I try to do those cages rather than doing the cages that already been discussed. Okay, so in this way, what happens, like with both theory and role play, we finish most of the questions. Cool. Is there any question that you want to ask about the course or anything you are having confusion? You can ask me now, or also you can ask us through the messenger or email. So thank you all. Have a good night. Bye. And someone asked about the management of heart failure. So Dr. Nargis, the management of heart failure, obviously you need to admit the patient in the hospital, and then this patient needs to be under the care of cardiologist. So you admit the patient, call your senior, and ask for review by the cardiologist. You order the investigations that I have said. And in the meantime, the first line management will be make the patient in propped up position, give oxygen if having shortness of breath or saturation less than 94, and start with furosemide or any water pills, mainly diuretics. Okay, so that's the first line management, and then the cardiologist will do the further management according to the underlying cause. Yes, we have shortness of breath cluster for respiratory system, then we will do the shortness of breath cluster. And any heart failure patient who is acutely severe, that patient should be sent to the ED, not in the GP setting. In the GP setting, you cannot manage it. Okay, then have a good night. Bye.